Let's open with the question that sits underneath almost every other question about ADHD medication, even when people don't say it out loud. If I take this, am I still going to be me? It's a fair question. It's also, as we'll see, a question with a more reassuring answer than most people expect once you actually understand the mechanism. So let's build this properly. There are two major categories of FDA-approved medications for ADHD: stimulants and non-stimulants. Let's take them one at a time. Stimulant medications are the most extensively studied and, according to the current research base, generally the most effective category of medication for ADHD symptoms. This category includes methylphenidate-based medications. Brand names like Ritalin and Concerta are methylphenidate, and amphetamine-based medications like Adderall and Vivanza. I know stimulant sounds alarming to some people, especially paired with a mental image of illicit stimulant misuse. So let's talk mechanism, because it explains a lot. These medications work primarily by increasing the availability of dopamine and norepinephrine in the brain's synapses, particularly affecting circuits in the prefrontal cortex involved in attention regulation, working memory, and impulse control. The exact circuits we discussed back in Episode 1 as being implicated in ADHD. Here's the counterintuitive part that surprises a lot of people. In someone with ADHD, these medications don't typically produce a euphoric high the way they might in someone without ADHD. Instead, they tend to produce a subjective sense of mental clarity, calm, and improved focus. This isn't a coincidence. It reflects the fact that ADHD brains, on average, appear to have differences in baseline dopamine signaling, and the medication is, in effect, helping bring an underactive regulatory system closer to typical functioning, rather than artificially amplifying an already typical system. This is part of why appropriately prescribed stimulant medication, taken as directed for diagnosed ADHD, functions very differently from stimulant misuse. Non-stimulant medications are the second category, and they're used either as a first-line option for people who can't tolerate stimulants, who have certain contraindications, like some cardiac conditions or a history of substance use disorder, or who simply prefer to start with a non-stimulant approach. This category includes atomoxetine, brand name Strattera, which works primarily on norepinephrine, and certain alpha-2 agonists like guanfacine extended release and clonidine extended release, which were originally developed as blood pressure medications and were later found to have benefits for ADHD symptoms, particularly around impulsivity and emotional regulation. Non-stimulants generally take longer to reach full effect, often several weeks, compared to stimulants, which typically show effects within the first dose or two, and non-stimulants are, on average, somewhat less effective for core attention symptoms than stimulants, though individual response varies considerably. Now let's talk about what the evidence actually shows regarding effectiveness. Multiple large-scale studies and meta-analyses have found that stimulant medications produce meaningful improvement in core ADHD symptoms for a majority of patients, and they remain, per current clinical guidelines, including those referenced by the American Psychiatric Association, a first-line treatment option for adult ADHD. That said, and this is important, medication response is individual. Not everyone responds to the same degree, and finding the right medication and dose is often a process of careful titration and adjustment with your prescriber, not a one-size-fits-all solution obtained on the first try. Let's address the questions people are actually afraid to ask, because avoiding them doesn't serve anyone. Question 1. Will this medication change my personality? This is one of the most common fears, and it's worth taking seriously. Appropriately dosed stimulant medication should not flatten your personality, make you feel like a robot, or fundamentally change who you are. If someone describes feeling zombie-like, emotionally blunted, or not like themselves on a stimulant, that is a recognized sign that the dose may be too high or the specific medication may not be the right fit. And it's a reason to go back to your prescriber for adjustment, not a reason to assume this is simply what ADHD medication does. Well-managed treatment should feel like access to more of yourself. Better follow-through, clearer thinking, not less. Question 2. Is this addictive? This deserves an honest, nuanced answer rather than a flat yes or no. Stimulant medications are classified as Schedule II controlled substances by the DEA, which reflects a genuine potential for misuse and dependence, particularly at high doses, when used without a prescription, or when taken in ways other than prescribed, like crushing and snorting a pill for a rapid effect. This is a real risk that responsible prescribers take seriously, which is why controlled substance prescribing involves monitoring, regular follow-up, and careful dose management. However, and this is a critical distinction the research supports, when stimulant medication is taken as prescribed, at appropriate therapeutic doses for diagnosed ADHD, the risk profile is substantially different from recreational stimulant misuse. In fact, some longitudinal research has suggested that appropriately treating ADHD in adolescents may be associated with a reduced risk of later substance use problems, likely because untreated ADHD itself is an independent risk factor for substance use disorders, partly through the impulsivity and self-medication pathways involved. The honest, complete picture is this. Real misuse potential exists and should be discussed openly with your prescriber. And appropriate prescribed use for a genuine diagnosis is a different risk category than illicit use. Question 3. Isn't taking medication just cheating or a shortcut instead of building real discipline? This is less a medical question than a cultural one, but it causes real harm, so let's address it directly. Nobody says a person wearing glasses is cheating at seeing, or that someone using insulin for diabetes is taking a shortcut instead of building willpower. ADHD medication addresses a documented difference in neurotransmitter regulation. It's treating an underlying physiological pattern, not providing an unfair advantage over some assumed neutral baseline. Framing it as cheating reflects the same misunderstanding we corrected back in episode 1, that ADHD is a discipline problem rather than a neurodevelopmental condition. Let's cover common side effects honestly, because a course claiming to be evidence-based shouldn't skip this. Common stimulant side effects can include decreased appetite, difficulty falling asleep if taken too late in the day, increased heart rate or blood pressure, and sometimes a rebound effect as the medication wears off, where irritability or symptoms temporarily worsen. Some people experience an initial adjustment period with side effects that improve over the first few weeks. Cardiac history is an important consideration prescribers evaluate before starting stimulants, given their effects on heart rate and blood pressure, which is part of why an evaluation should include relevant medical history. Non-stimulants carry a different side effect profile. Atomoxetine can cause nausea, fatigue, or in rare cases, has an FDA-boxed warning regarding suicidal thinking in children and adolescents that prescribers discuss. Guanfacine and clonidine can cause sedation and drops in blood pressure. None of this is meant to alarm you. It's meant to reflect the actual honest conversation a good prescriber has with a patient, which is exactly the kind of conversation this course wants to model. Let's walk through 2 examples. First example. Kevin, 39, started a low dose of extended-release methylphenidate after his diagnosis. His initial reaction was mild appetite suppression and some trouble falling asleep, both of which improved somewhat after his prescriber adjusted the timing of his dose earlier in the day. Within a few weeks, at an appropriately titrated dose, he described being able to complete a task from start to finish without my brain trying to escape the room, while still feeling entirely like himself in conversations, decision-making, and his sense of humor, which is exactly the kind of response that reflects appropriately dosed treatment. Second example. Monica, 44, tried a stimulant first but found the side effects, particularly a persistent increase in anxiety symptoms, difficult to tolerate despite dose adjustments, a real and recognized possibility we touched on back in episode 4 regarding the anxiety ADHD relationship. Her prescriber transitioned her to guanfacine extended release instead. It took about a month to notice a full effect, slower than the stimulant had worked. But it provided meaningful improvement in impulsivity and emotional reactivity, with a side effect profile she tolerated much better. This illustrates an important point. Medication choice is genuinely individualized, and a first medication not working well doesn't mean medication as a category has failed. It often means the specific medication or dose wasn't the right match. Clinical perspective. Prescribers typically start at a low dose and titrate upward gradually, monitoring response and side effects rather than jumping to a high dose immediately. Follow-up appointments in the early treatment period are usually more frequent, sometimes every few weeks initially, specifically to fine-tune dosing. This is normal and expected, not a sign that something has gone wrong. Let's correct a few more misconceptions directly. Misconception 1. Once you find the right medication, you're done. No more effort needed. Medication is genuinely effective for many people, but current clinical guidance, including recommendations reflected in APA resources, generally supports combining medication with behavioral strategies and, when appropriate, therapy for the most complete and durable results, particularly for the organizational and habit-based challenges that medication alone doesn't fully resolve. We'll cover these non-medication strategies in detail in our next episode. Misconception 2. Medication works the same way for everyone, so if my friend's dose works great for them, that's probably the right dose for me too. Dosing is highly individualized based on body chemistry, symptom severity, coexisting conditions, and side effect tolerance. There is no universal correct dose, and sharing or self-adjusting controlled medication is both medically unwise and illegal. Misconception 3. If medication doesn't work perfectly on the first try, it means ADHD medication just doesn't work for me. Finding the right medication and dose is frequently an iterative process. Many people try more than one stimulant, or move between a stimulant and non-stimulant category before landing on what works best for their particular physiology. Practical takeaways. Medication decisions are collaborative and individualized. They belong between you and a qualified prescriber who knows your full medical history, not in a comment section or from a friend's experience. Effectiveness, side effects, and the right category of medication vary meaningfully person to person. A well-matched medication and dose should help you access more of your genuine self, not replace it. And medication, while often highly effective, works best as part of a broader treatment approach rather than a standalone solution. Which brings us to exactly where we're headed next. Medication is one major pillar of ADHD treatment, but it is not the only one. And for some people, due to personal preference, medical contraindications, or simply wanting a fuller toolkit, non-medication strategies are just as essential. In the next episode, we're covering therapy, coaching, and behavioral strategies that have real evidence behind them.